Okay, so I was a little unsure of exactly what we were supposed to do. I do have the fluid and electrolyte flip book of I think Mosby's note cards, but instead of using those, since a lot of them were on our PowerPoint, I decided to really focus on a lot of the information that our book had. So the first ones that I looked over was obviously sodium and chloride, and we know that those are kind of like sisters. They kind of support each other, and basically what that means is that chloride always follows sodium. So, sodium, basically, I kind of did a big one for each topic. So I have that sodium accounts for 90% of the extracellular fluid cations. We know that it regulates water balance, regulates acid-base balance. It's involved in cellular chemical reactions, maintains the neuromuscular irritability for the conduction of nerve impulses, and it transports substances across the cellular membrane. Minimum daily requirements for people are around 500 milligrams, and we end up taking in 5 to 6 grams with our diet anyway. As for hyponatremia, which is low sodium, serum sodium less than 135, can have lethargy, I always mess that up, lethargy, headache, confusion, seizures, coma, and then hypernatremia, so too much, having greater than 147, can cause thirst, fever, hypotension, tachycardia. So then for chloride, we know it follows sodium. So if sodium leaves, chloride also leaves. So if you have low sodium, most likely you have hypochloremia. Not enough chloride, so less than 97. And if you have hyper, you have too much. And basically, chloride is a major anion in the extracellular fluid. It provides electroneutrality in relation to sodium. Its transport is generally passive. Like it said again in the book, the changes in sodium are proportionate to the changes in chloride. And chloride actually inversely changes in relation to the concentration of bicarb. I didn't know that. So then we move on to potassium. Daily dietary intake is between 40 to 150 MEq per liter daily. It's a major intracellular electrolyte, and it's found in most of our body fluids. So potassium balance is maintained by renal excretion. The extracellular fluid levels of potassium is usually 3.5 to 5, and the intracellular is 150 to 160. Any absorbed dietary potassium moves rapidly into our cells, but actually aldosterone, insulin, epinephrine, and alkalosis all facilitate potassium shift into our cells. As for hyperkalemia, having too much, it's extremely rare. Doesn't happen very often. Greater than 5.5, it causes muscle weakness, paralysis, cardiac dysrhythmia. And then hypokalemia, not enough. Really, there's not a lot of clinical manifestations, but if it's severely low, like less than 2.5, it can cause severe neuro and cardio deficits. Again, with the muscle weakness, paralysis, and dysrhythmias. So then we get to calcium and phosphate, and they're usually kind of seen as friends or sisters too, and they kind of go together. So calcium is basically regulates a lot of our metabolic processes. It works with blood clotting, hormone secretion. It's a major cation for the structures of our bones and teeth, which I'm sure all of us know. And it also controls nerve impulses and contraction of muscles. Ionized calcium has the most important physiologic functions for our bodies, and 99% of calcium is found in our bones. So, hypocalcemia, not having enough, causes neuromuscular excitability, and hyper, which is having too much, causes fatigue. It can cause changes in our mental status, anorexia, things like that. As for phosphate, 85% is found in bone. In the intracellular and extracellular, it's an intracellular and extracellular anion buffer that regulates the acid-base balance in our body. And basically, phosphate and calcium are both regulated by PTH, vitamin D, and calcitonin. As for too low, the hypophosphatemia, there's really not a lot of evidence clinically just for that. And then for hyper, having too much, it is related to hyperphosphatemia is related to hypocalcium. So they kind of go together. And then long-term, too much phosphate can actually lead to calcification of the soft tissues like the lungs, kidneys, and joints. Then we get to magnesium, major intracellular cation. It's a cofactor in intracellular enzyme function, protein synthesis, nucleic acid stability, and neuromuscular excitability. 40 to 60% is stored in muscle and bone, 30% is in our cells. Hypomagnesemia can cause confusion, irritability, convulsions, similar to hypocalcemia. And then hypermagnesemia can cause nausea, vomiting, muscle weakness, hypotension, bradycardia, and even respiratory depression. And then, like I said, there are those really cool Mosby's flashcards, and I do have that book. Before submitting my actual concept map, I'll probably kind of fine-tune what I did tonight for the discussion, but I just kind of wanted to cover all the bases of what our book actually has written out for that, and then I'll probably study the Mosby's note cards just as a supplement. So